one of those meetings.
Turn it up. I can
I
hear it.
had it.
Okay, I'd like to welcome everyone to Resnik Grand Rounds. Thank you for taking time tonight. We have a great topic to talk about, and also Dr. Hussein has 5 really good cases that we're going to go over. So just as we talked about in the past, we have Dr. Hussein Tarek. He will be coordinating all the CBCT scans and the treatment planning. He's from ITX. He's a prosthodontist and their clinical director. Also, what we have changed up or added to our Resnik Grand Rounds is we have our clinical director of the Resnik Implant Institute, Dr. Rick Robinette, also our F-16 fighter pilot before he started practicing implant dentistry. But anyway, he is with us tonight, and we have had some questions on how doctors can get their questions answered. So basically, on the chat here, you can put your question, type it in, and Dr. Robinette will answer your questions while I am lecturing. So with that being said, I'd like to go right into our topic for tonight in our clinical pearls in implant dentistry. I usually go over a controversial subject, and I had this interesting case in the last month, and I would like to share it with you because I think there's a lot of good information and lessons you can learn from this case. So let me tell you a little bit about it. This is one of our graduates, and they presented this case to me where this patient was referred to them by a surgical doctor who placed the implant, number 19. It was placed approximately 3 months ago. It was referred for the final prosthesis. There was no mobility or infection. However, as you can see, there was bone loss. The patient supposedly has poor hygiene. The surgical doctor who placed the implant believes this is why the bone loss occurred, and he was asking our graduate to go ahead and restore it. Medical history is a patient is a diabetic. However, the A1C is unknown. If we first look at this, and why I thought this was a great case to go over on Grand Rounds is you have to be very, very careful in getting involved in cases similar to this. Number one, if we look at this case, what is the prognosis of this? What is the long-term prognosis? If we look at the bone loss, yes, there is bone loss. How significant is this bone loss? And does this bone loss put the prosthesis and the potential implant at risk? So those are the questions I want to answer. Also, what are the other options this patient has? So if we look at answering this first question, how did the bone loss occur? Was it a treatment planning error, surgical error, force related, or was it poor hygiene? So that's what I'd like to go over first. If we look at ideal placement of an implant, we know when we place it into bone, we should have at least 2 millimeters of bone on the facial, 1 on the lingual. Why is that? Because that will maintain the health of the bone and also the soft tissue overlying that. What I see in a lot of cases where there has been resorption, so the ridge narrows from a division A to a division B, and what ends up happening is that you place the implant and then there is not enough blood supply for that buccal plate to be maintained and you start to lose it. Then what happens? Well, the doctor who places the implant says, okay, I'll just do some bone grafting, place some bone grafting on the buccal. When you're taking 2-dimensional x-rays, you can never tell if that bone actually took or not. And what usually happens is, if you remember about bone grafting, there can't be any micromotion. If there's micromotion of the actual implant, then that becomes problematic. When it becomes problematic, what I mean by that is it usually doesn't take and it usually don't grow any bone volume. Therefore, in this case, what I believe most likely happened is the ridge was very thin. the implant was placed. During the healing, the 3 months of healing, the ridge resorbed or remodeled lower. So approximately 4 to 5 millimeters of the ridge was lost. This leads us into what are our treatment options. So you as a restorative dentist can go ahead and restore it. We're going to talk about that. You could also graft it and then restore the implant. You could remove the implant and place an immediate implant, or you could remove the implant, graft it, and then wait for everything to heal and then place an implant. So let's go through these 4 options and see which one is the most logical. If we restore the implant, if you as a restorative dentist go ahead and restore it, now you basically are jumping on the train that is out of control. There is a significant existing bone loss. And even though it is integrated per se, and it doesn't meet the criteria that we usually use to remove an implant, however, it hasn't been restored. So there has not been any force on this, and it's already lost bone, which is a problem. And it's significant amount of bone. And if you can see, multiple threads are exposed. So before we talk about this, you have to understand there is a term called the crest module. What is the crest module? The crest module is that part of the implant, which is the neck of the implant, which is responsible for maintaining the crestal bone. The reason it is a different design than the threads of the implant lower in the implant or towards the apex is that the micro threads are a lot better for the cortical bone. So when we look at this very top part of the crest module, there is a collar. Some implants don't have a collar, some do. The one that I'm showing you does have a polished collar. The theory behind the polished collar is because it is so smooth, biofilm or bacteria will not adhere to it. Therefore, the soft tissue will be more ideal. Underneath that polished collar is these micro threads. And I said, these are specifically designed for cortical bone. They allow better stress distribution and it increases the surface area because there's more threads and they're deeper threads. Therefore, this area is very, very important. And the why these micro threads, they prevent bone loss. We know that when force is placed on an implant, the greatest amount of force is on this crestal area. So the design of the implant is very important with these micro threads. And ideally, when there is bone up against the micro threads, that is perfect because that bone has very good primary stability that turns into good secondary stability, and it maintains itself very well because of the distribution of stress. However, when you don't have bone up against these micro threads, what ends up happening is you can see this image on the right. That is biofilm and bacteria adhering to it. So it's a roughened surface. Because it's a roughened surface, this leads to problems. What are the problems? Well, I have these little yellow bacteria that I just want to show you. They accumulate onto this roughened surface, and it's very, very difficult to remove them. A patient in their normal hygiene cannot remove them. It's almost impossible. Therefore, when you place bone up against them or to try to grow new bone up against these exposed microthreads, it won't happen because it will not allow that integration, that new bone to form on it because there's a film, that biofilm will prevent it. Therefore, what I usually get from doctors is I'll get the phone call, Randy, hey, can I have the patient sign what is called a high risk consent form? Meaning this implant is not ideal. However, if the patient signs a piece of paper saying that they're going to take the risk, then I can go ahead and do it. And I've been involved in defending dentists for over 30 years, and I can tell you, not once in my career of doing this have I ever seen one of these forms actually be admitted into evidence. So what usually ends up happening is it is not a get out of jail card, which most people think. What it ends up being is the patient says, well, I signed it under duress, or I didn't understand because I don't have the education to understand it, or I'm not fully capable of understanding the current situation, which is true. So there's a legal and ethical consideration with these forms. Yes, you can get them signed. Is it better to sign one than not? Probably yes. But what ends up happening is this, that if this would go the wrong way and say this would get litigious. In this case, the dentist would probably be held for liability because of deviation standard of care or negligence. They will get some plaintiff expert to say that it shouldn't have been done. It was failing. It should never have been done. So the first thing I want you to do is be very, very careful. You think that a patient signs the chart or this and that, it is usually thrown out in my experience because they don't have the education. Now, that is treatment plan one. Let's talk about treatment plan two, where we're going to graft it and then we're going to restore it. So we're just going to put some graft material there. However, as I stated, no graft material will adhere to this, or you will not get integration of that bone into those threads because of the biofilm. You have to be able to clean the biofilm off. So what ends up happening is the bone will fall away from it, and also the micromotion of that bone. It's very difficult to keep that bone stable to where the body will remodel it. Now, there are some ways that we can increase the chances. One way is to do an implantoplasty. These are specialized burrs from Selvin that you can actually remove the micro threads or the threads of the implant, and you smooth them down. Some implants you can do it, some you can't. Some, if you remove the threads, it'll make it too thin, and then you'll end up with an implant fracture. This is a peri-implant disease protocol. Most everyone knows Dr. John Suzuki. He's probably the most famous periodontist in the whole world. He and I have a peri-implant disease protocol. If you are taking our third module, we actually have you do a lab on this where you go through and we'll show you how to detoxify and do an implantoplasty on implants. But there is multiple steps. You're using tetracycline, you're using citric acid, Paradex, hydrogen peroxide, possibly lasers, and then grafting it. That is how you actually have to proceed on these cases, but they're very, very difficult and unpredictable. That leads us to treatment plan three, where we remove the implant and just place an immediate replacement. And there's many problems with this. Yes, we can take the implant out, place another implant. It would be more apical. And because it's more apical, it's going to cause some issues. I have three issues here that it can cause. First is when you remove the implant, you're going to remove bones. Secondly, trying to get primary stability. And third, the location of that implant is going to be a poor crown root ratio. So if we first look at implant removal, an implant that usually fails is mobile. So that means it has a soft tissue interface. This is a histologic section of a failed implant. In the red is all soft tissue. Therefore, there is no bone integration into the implant. It's very easy to remove. How do we remove it? Reverse torque it. Usually it comes right out, not a problem. In this case, it's not mobile because the lower 2/3 of the implant is integrated. Because it's not mobile, in the green in this histologic section is bone. So those bone has actually grown into the implant. To remove an implant like this, it's very, very difficult. We certainly don't have enough time to go over that. In the resources section of all the modules, I have a webinar on how to remove integrated implants. And if before you try to do that, make sure you read that or watch that, because they're very difficult. There's a high morbidity. You can end up with real bad infections, osteomyelitis. I've even seen jaw fractures from it. So you have to be very, very careful. So the bottom line is, to remove this implant, you're going to have to remove a lot of bone just to get it out of there. Therefore, once you remove the implant and then try to place an implant, you're not going to have very good primary stability. And we know if we don't have good primary stability, then we don't have good secondary stability. And thirdly, look at where that implant is going to be positioned. It's going to be a very poor crown to implant ratio, very non-ideal. It's going to be a vertical cantilever, and that just is not a good plan. So that leads us to treatment plan 4. Remove the implant, graft it, and delayed replacement, which is probably the best option here. However, this case has other issues. So the more I looked at this case for the doctor, I said, you know what? You have a nerve very close here, so you possibly could end up with a neurosensory impairment just because we have to deepen our osteotomy to place this implant. Or we could perforate through the lingual plate. We know that the sublingual vessels, the sublingual artery, and the submental artery is on that lingual plate. So we have to be very careful with that. In addition, I looked at number 20 on the CT scan. Now, CT scans are not the ideal radiograph to evaluate the health of a natural tooth, but I can see right here, there is definitely some issues on number 20. So that's another thing I told the doctor. You have to determine the prognosis of number 20. So my recommendations on this case, before you do anything, you have to determine the diabetic control. You have to see if this patient is a uncontrolled diabetic where nothing is going to work here. Secondly, you're going to have to remove this implant. You want to remove it with as least traumatic as possible. You're going to graft it. You're going to delay the implant placement. After the evaluation of number 20, then you're going to decide, is it going to be removed or is it going to stay? And never blame the patient, which I'll get to here in a second. Now, if number 20 is going to be maintained, my recommendation, because of the port to crown implant ratio, because of the poor bone quality, my recommendation was add another implant. Splint them together. That will counteract that vertical cantilever. It'll be a lot more ideal, because where this implant is going to be, it's going to be below if you look at that number 20, it's going to be almost at the apex of number 20. Number 2, if number 20 is not have a good prognosis, remove it. Go ahead and graft that site, graft number 19, and then place an implant 19 and 20 and splint them together, and that will counteract the occlusal force issue that you have. And lastly, I run into these cases all the time where I see doctors tell patients they're not cleaning, especially right after the implants are placed. Remember that if you look at the studies that have been done over the years, that really doesn't happen. Probably the best pioneering study on force and hygiene was Isidore's study in '96. It was a monkey study where they put one group in hyperocclusion. So one side was in hyperocclusion, about 63% of the implants failed. The other group, what they did is they did a ligature-induced peri-implantitis, no occlusal load. There were no failures on that. So what is this study telling us? That early in the implant osseointegration phase, hygiene doesn't have much to do with it. It is more later on. So you have to be very, very careful with that. So occlusal stress is more actually a bigger contributing factor to implant loss than bacterial. And as you remember, the prevalence of perimucositis, which is analogous to gingivitis, these are systemic and meta-analysis reviews here, all in the last probably 10 years, here all the way from 43% up to 80%. It's really high and the incidence is significant. And peri-implantitis, where you have bone loss, which is analogous to periodontitis, over 20%. So the moral of this story is be very, very careful. I told this doctor, do not restore that implant. The patient might be your best friend now, but if that implant fails, or if some other doctor tells them down the line it should have never been restored, then things will change. Okay, so with that being said, is Dr. Hussein on?
Yes, sir. I'm here.
Okay, let's go to it.
Yes, Doc. Here
And
we
while
go.
he's getting the first case up, if there's any questions on that mini lecture I just gave, again, Dr. Robinette is on, and he will gladly answer any questions. So go ahead, let's go for it.
Dr. Resnik,
First
would you mind
case.
stopping sharing your screen and I'll have it right away,
Okay,
sir. Here we
how's
go.
that?
Thank you, Doc. So first case is for Dr. Tomasi today. Dr. Resnik, Dr. Tomasi, would you mind unmuting yourself, Doc, and taking us through your case?
Hi, Dr. Tomasi, how are you? Is she with us? Okay.
Yes, I
Doc,
think she is, Doc, but she's on mute.
okay. Okay. So, Dr. Tomasi, could you give us a little history on your
Hello?
patient here? Hi, Dr. Tomasi. How are you?
I'm good. How are you, Dr. Resnik? The phone
Good.
got
You
stuck
always have great
somewhere.
cases. So, thank you for sharing them with us today. So, tell us a little bit about your patient, Doc.
So the patient is a 39 years old female attorney. So it has to go smooth.
We won't hold that against her. Go ahead.
And she just came to our practice with the chief complaint that she needs to restore missing tooth number 5. I believe about a year ago, the extraction was done along with the bone socket grafting. And
Okay.
so I took CBCT scan and submitted to ITX Pro for evaluation. The patient's
Okay.
medical history is significant for a hip replacement in 2023, ADHD,
Okay.
and some back pain. She's allergic to penicillin. She's
Okay.
taken muscle relaxant and she's taken Adderall and some Ayurvedic medicine.
Okay.
That's what it's called, but I believe it might cause a bleeding.
Okay, good. So let's take a look at the scan. So Dr. Hussein, can you give us a 360 on the 3D image here?
Yes,
See,
sir.
and could you remove that tooth? Perfect. Okay, Doc. So I lost a little bit of the buccal plate, but not bad, not bad. Let's go ahead and let's look at a cross section here. So he is highlighting where the buccal plate has become a little bit concave. So we know the bone always resorbs from the buccal to lingual. Go
Mhm.
ahead, give us a cross section here.
Here you go, sir.
Okay. Did you work this one up, Dr. Hussein?
Yes, sir, we did. We did add the 4.3 by 13 millimeter Han tapered implant over here, Dr. Resnick. Go ahead, sir.
Okay. Okay, so where Dr. Hussein has this implant is ideal. See how it's going right into the buccal cusp of that
Right.
mandibular tooth. So he has it positioned great. What I would like about this also is he has favored the lingual plate more than the buccal plate. We always want as much bone on the buccal. That way we're going to maintain the bone and the soft tissue. The lingual plate is always a lot thicker as it widens out. So I like this position. Let's look at it on the 3D image to see where it's coming out
Actually,
angulation
when I was
wise.
submitting the case, I mentioned that I use 3i or Biomeds in the implants,
Oh, you
not
know what?
hand.
Okay, they can switch that for you. They can
Uh-huh.
switch that for you. Yeah. Were you going to do this guided, Doc?
Uh, I'm thinking about maybe freehand or just with the pilot guide.
Yeah.
What do you
I
think?
tell you, Doc, as you know, I love the pilot guides. Pilot guides
Mm-hmm.
make it so easy. You do the first drill. It gives you the mesial distal buccal lingual angulation, and then you go ahead and freehand it. With that being said, I would pilot guide would be a good choice here. Now,
Uh-huh.
Dr. Tomasi, I know you've come to hands-on. You are well versed in this, but just we do have some doctors early on their learning curve. This is the best case if you want to look for if you've never done an implant before. Dr. Tomasi's case is perfect. It is the maxillary first bicuspid. Why that is so good is there is no vital structures. You can look right up into the edentulous area. Bleeding usually is not an issue. If you have to use a guide, it's very simple and easy. And this is where you should start. I get a lot of doctors that want to do their first case right over the inferior alveolar nerve, not an ideal situation. So if you want to do your first case, start looking for an upper first buy. The second option would be a second buy. You're almost always anterior to the sinus. This is a great case. So Doc, I would say you have a good case here. He'll switch
Mm-hmm.
out your implant for you. And if you want to do that pilot, I would certainly not do it fully guided, but either do
Yeah,
it pilot guided or
I
freehand.
agree. Yeah, yeah.
Okay.
Thank you very
And
much, Dr. Resnik.
hey, thank you for sharing that with us. You always have
My
good
pleasure.
cases and you're
My
always on
pleasure.
the ball. I love it. Take care, Doc.
Thank you. You
Okay,
too.
let's go. Who's our second doctor?
Next case is for Dr. Tristeza. It's an upper and a lower case, Dr. Resnik, and I'm loading it right now on my screen. Dr. Tristeza, would you
Okay.
mind unmuting yourself, Doc, for us, please?
Yeah, I'm right here.
Hi, Doc. Hi, Doc. How are you?
I'm doing well, sir. How about you?
Good, good. You bring us a good, nice case?
Yes, sir.
Okay.
I have a 60-year-old.
Oh, yes. Oh, good. Okay. What do we have? How old's the patient? 60 years old.
Yes, she's a
Uh,
62-year-old female. She's been smoking for over 10 years. But we talked about smoking cessation and so that way, she can heal well. And we
okay.
did extractions on the lower around late November, early December, and we're planning to do
Okay.
mandibular overdenture.
Okay. So you're looking to do an overdenture. Now, Doc, what is going on in the maxilla? Are you planning on replacing the posterior segments or does this patient have a partial?
At the moment, we're not planning to do anything on the maxillary. I think she's just, wanting just to do something with the lower. I think she is wearing a partial on the top.
Okay. And
Mhm.
the mandibular teeth, why were they removed? Were they periodontally involved, decayed,
Yes, sir. They were.
fractured?
They were periodontally involved, and it was on three teeth. It was from trying to remember. It's like 24 to 26. I want to say.
Okay. Okay.
Mm.
So the reason I asked that, Doc, is I'm just looking at the pan here and I see that anterior segment, how it is a little bit higher. It looks
Mm.
like probably through the periodontal loss, the bone loss, and the extrusion of those teeth. We also got a little bit of extrusion of the alveolus. Why I
Mhm.
say that is that becomes a little bit problematic when we're looking at how much restorative space we actually need. So that
Mm.
this is probably where the ideal or where the bone level was when her natural teeth were not periodontally involved. But whatever, let's move forward. Let's go ahead and let's take a look at the 3D image.
Yes,
Okay.
sir.
So he's going to give us a 360. Yeah, move. Perfect. So what I like to do is look at it from a 360 and keep moving that around. Okay, keep moving that around and show them the anagonial notch.
Yes, sir. Here we go.
So for some of our newer doctors on tonight, see this little notch here? That is the insertion of the masseter muscle. When you see it concave like that, that means it's worn out. That means that the patient has masseter hypertrophy, and it's sometime or possibly right now does have some parafunction. With that being said, we just have to take that in consideration. This is going to be an overdenture, so it's going to be a little bit different than a fixed prosthesis. The next thing we're going to look at is, if I look at this mandible, doc, there is an angulation, a little bit of an angulation issue on this, where the resorption pattern has really been significant going from buccal to lingual. This is almost, if you remember, we have a division A, division B, division C bone. This is almost what we call division C-A, which would be a division C bone because of a overangulation of the bone. So I'm glad that you are doing an overdenture. I think an overdenture would be a lot easier than doing a fixed prosthesis on this case. With that being said, Doc, did you discuss with the patient the two types of overdentures? The
No, sir.
RP4. Okay. So for everyone on the webinar tonight, there are two types of overdentures. One is an RP4. The second is an RP5. An RP4 would be totally implant supported, meaning that there would be no soft tissue support whatsoever. You get all of your support from the implants. An RP5 is where you get the primary support from the soft tissue. Secondary support is from the implants. With that being said, did you talk to her, the patient, about how many implants?
I mean, we were talking about doing 2 to 4 implants, but I was having this presented to see, what would you say would be the best case for?
Okay. So that's good. So, Dr. Hussein, have you worked up any implants on this case?
Yes, sir. I did plant 5 implants intraforaminally at the A, B,
Okay.
C, D,
So,
E
so
position.
could we put the pan on and then highlight your implants that you placed?
Yes, sir. Right away.
Okay, so we'll make that full screen. Oh, okay. So Dr. Hussein put 5 implants in.
Okay.
So what we're looking at is, because there's going to have to be an osteoplasty here to create restorative space, and we'll talk about restorative space here in a second, because we have to determine how much bone we actually have to remove. If we look at this case, he has put them in the A position. Show them the A position, Dr. Hussein. Actually, the
Here you go.
opposite.
Oh,
Yeah,
sorry about that.
right here, A. Okay. Then B is right next to it, C, D, and E. So if we're looking at 2 implants, we usually will place them in the B, D position. So let's remove ACE. If you can remove the ACE implants and just
Right
BD.
away, sir.
Okay.
Here.
So Doc, you can do 2 implants. This would be a lot better than wearing a denture for the patient. However, do you remember when I talk about a 2-legged chair? Explain to the patient 2 implants is like sitting on a 2-legged chair. You can stabilize it, but you're going to be able to move it back and forth. 2 implant overdentures work nice in patients who have had dentures for a long period of time. However, if this patient wants a little bit more retention, 2 implants might have a little bit of rotation, especially because they have some significant tori here. So that might be an area of sore spots. So 2 implants is one option. I'll tell you, if my recommendation on a patient like this, because what I don't like, which is not going to be the most ideal, Doc, is your plane of occlusion. You have maxillary teeth that are probably not in the best position, plus a partial that the patient may or may not wear. So what ends up happening if the patient is only incising on those anterior 6 teeth, what they're going to do is it's going to be a teeter-totter. They're going to bite in the anterior, and that posterior is going to flip back and forth. So if you do 2 implants, let them know it's like a 2-legged chair. You must have good extension into the buccal shelf. which is the primary stress bearing area. My
Okay.
recommendation is not 2 implants. Put the ACE in, and I'll tell you why I like ACE, Doc, better. Let's look at it from the occlusal view on a 3D image.
Right away, sir.
So see how this increases our AP spread, Doc?
Yes, sir.
So by placing ACE, we have the implants posterior and we have one anterior, which is ideal. So it's going to have a greater stability in the anterior. We're going to have less rocking in the posterior. Now, Dr. Hussein, put the B and the D position in, take out the C. Because, Doc, you had mentioned 4 implants.
Mhm.
Now, what is wrong with this? What is wrong with 4 implants? I would rather have a 3 implant overdenture than a 4 implant overdenture. Why? Look at the AP spread. We don't have anything in the anterior. We don't have an implant in the anterior. So by putting 4 implants in, you're really not gaining much other than you're putting just an extra implant in and possibly getting more retention. However, 3 implants, I believe you said locator. Did you say locator, Doc?
Yes, sir.
Okay. I think ACE would be a home run for you on that. Okay.
Okay.
Now, the only question we have on this case, let's go back to the 3D images with the maxilla and the mandible.
Absolutely, sir.
Okay. So, Doc, what I'm going to show you here in a second is something that is very important because as you know, with an overdenture, that you have an acrylic denture, and then
Mhm.
you have to have a locator attachment. Then you have to have bulk of acrylic to hold those attachments in. If we look at this space right here, and we don't know if that's a correct vertical dimension or not. However,
Right.
just by looking at it, I believe that you're probably going to have to take off a significant amount of bone. We don't know how much bone you really have to remove. So if you want to make this case, do you have a CT scanner in your office, Doc?
Yes, sir. A VA, VA
Oh,
CBT, VA Tech
oh,
CBT.
perfect. Okay. So let's look at it straight on, Dr. Hussein.
Here you go, sir.
Okay. Okay. So if if you could take another scan, but take a dual scan.
Okay.
And Doc, what I mean by that is, you know how you're going to take the scan with the patient's denture, and then you're going to just take a scan of the denture. You're going to put those radiopaque balls on. By
Mhm.
doing that, it's going to allow us to be able to know where the teeth need to be, and we're going to be able to measure how much bone that you need to take away. The
Okay.
worst scenario that you could have on this case, especially with the super eruption of these maxillary teeth, is that you don't have enough bone or enough space for the prosthesis. And then they're going to be breaking the prosthesis or breaking the attachments. So my recommendation would be to just take a dual scan,
Mhm.
and ITX can work this up just perfectly where you know exactly how much restorative space, which will dictate how much bone you remove, and then place 3 implants. Does that make sense?
Yes, sir. And would you recommend like doing like a soft tissue surgical guide that's stackable, or would you do this freehanded? Like, what would your
I tell you, I have this. Let's go back to the Panorex. I think it might
Right
be
away,
easier to
sir.
see on the Panorex. Okay, below that. So, Doc, do you see, Dr. Saying, show everyone where the bone has to be removed on top of the implants. Okay, put the implants back in.
Here we go, Dr. Resnik.
Okay, show them on top, but you're also going to have to remove bone in the posterior because see that bone? See where he went all the way back? You're going to have to remove all that. This would be an ideal case for a stackable guide, or at the
Mhm.
minimum, Doc, a reduction guide, okay, where it shows you exactly how much to remove, and it will be a lot easier. So with that being said, you could make a soft tissue supported guide, do it via a pilot guide, or You can also do a regular stackable where you'd flap it, place a foundation guide, and then put the subsequent guides on top of that. So you could do either one. But what I would say, Doc, is there's an unknown here that we don't know, and that is how much bone we have to remove. I think
Mhm.
if you take that dual scan and work it up with Dr. Hussein, he's really good at this. It'll make this case go really smooth and easy. The first
Okay.
thing, though, I would talk to the patient about how many implants. What I would prefer two implants would not be the most ideal. I think three. Let them know a two-legged chair versus a three-legged chair. I think you have a good AP spread there. I think it would be a no-brainer. Dr. Hussein, do you agree with the dual scan on that?
100%, sir. It will give us a better insight regarding the restored space available.
Okay.
Okay, perfect.
Thank you. I
Okay, does that
appreciate
make sense, Doc?
Yes, sir.
Okay,
Thank you. I
so
appreciate it.
after you get that, have Dr. Hussein work it up and then have them send it to me so I can just see it, okay?
Yes, sir.
Okay, thanks for presenting.
Thank you.
Okay, let's go. We're having fun. Who's the
Next,
patient
next case is for
doctor number
Dr.
3?
Dr. Mark Soil, sir.
Oh, good. Hi, Doc. How are you?
Good. Doing well.
Good, good. So what do you have for us tonight? Tell us about your patient.
He is a 50-year-old male who had came into the office with a failed bridge and had neglected it for about 8 years. So the infection had gotten real severe in the number 9 position, and then he had a resorbed ridge in the number 10 position. So I did a socket graft in the number 9 position and
Okay,
attempted to do a ridge augmentation in the number 10 position, but I got a pretty bad result in a socket graft in the number 9 position. So he wants to have more bone and or soft tissue for a couple of implants, but I'm
okay,
questioning whether I can achieve that.
okay. Hello?
Dr. Mark, you're back on mute, sir. Would you mind unmuting yourself?
Yeah.
Perfect,
Okay.
we're back.
Hey, Doc, let's go back. First of all, Dr. Hussein, could you put the 3D image up and do 360 while I'm asking him? Um, why were these teeth removed? Did you say they were infected? Is that what you said?
And number 9 had a serious infection, a
Okay,
failed bridge. And so I did a
okay,
socket 9.
okay. So you did a socket graft in 9 and then a GBR on 10.
Right.
And it looks like 9 is definitely a little bit compromised. So let's first look at, okay, stop right there. Dr. Hussein, let's remove the teeth.
Right away, sir.
Okay. What I want to look at, Doc, is how much resorption we've had. So he draws a line for me. He's doing the buccal contour on where it
Mhm.
should be. Okay.
Right.
So right off the bat, Doc, we've lost 3, maybe even 4 millimeters there. Number 9, buccal to lingual. So that's pretty significant. Now let's look at, let's go ahead and look at the vertical loss. So if we can look at that straight on. Okay. Now draw another line so everyone can see it.
Right away, sir. Here we go, Dr. Resnik.
Okay. So Doc, see how we've lost vertical height too. So
Yes.
you know what my first question is going to be, don't you? Does this patient have a high smile line?
He does
Do
not
you know?
have a high.
Okay. He does not. Is that what you said?
Yes, he does not have a high smile
Okay.
line.
Very good. Very good. Okay. So right off the bat, just for everyone else on the webinar, you want to explain to the patient that this is not going to be an FP1 prosthesis, which is going to look like the adjacent teeth, meaning see how the length of those other teeth are? It'll most likely be a little bit hypercontoured or possibly even with pink acrylic, the way it is right now. So, right, if the patient had a high smile line, then an option would be not even to graft this case and just do a conventional fixed partial denture. However, because we don't have a high smile line, we're not worried about a little bit longer of a tooth. We can definitely look at evaluating these for the implant. So, Doc, what I first want to do is let's see how much bone we have. So, can you give us a cross section here on number
Right away,
9
Doctor.
and then number 10? So if you could blow the, okay, there we go. So that's number 9. So that was the socket graft. Okay. And let's scroll back to number 10. Okay. Okay. And Doc, how long ago did you do this again?
6, 7 months ago.
6 or 7 months ago. Okay. So let's go back to the 3D image. Okay.
Here we go,
So
Dr.
Doc,
Resnik.
perfect. So here's what I see, Doc. You don't have enough bone in number 9, and possibly you don't have enough in 10 to put an implant in. So your options are to regraft and to build this area back up, which I think you can very easily, or 2, change the type of prosthesis. If the patient really wants an implant, then they're definitely going to need a bone graft. If they're willing to go through the bone graft, that's probably the most ideal treatment instead of grinding and prepping virgin teeth there. Therefore, what I would say is let's look at it straight on, Dr. Hussein.
Here you go, sir.
Okay. So, Doc, do you remember when I talked about when you have an infection, you take out a tooth, the pH of that area is changed dramatically. It becomes more acidic. And
Yes.
even though that you take out the infection, sometimes that area is still compromised. So most likely what happened here is the environment to grow new bone was not ideal, and that's why not a lot of bone was grown. However, now it has been months since everything's been taken out. The body's been able to basically remodel this area. I think a second graft would be a lot more predictable, but it's going to be more like a GBR in both 9 and 10. Okay.
Right.
So what I would say is this can be done with probably about 4 screws. Now, what I would recommend is let us work it up. And ITX can actually make you a guide for the placement of the tent screws, and I can show you exactly where to put them to make it a lot easier. But the first thing you're going to do is you're going to flap this, and you can most likely do a patella sparing incision there that you'll be able to flap it enough, broad base. And then you're going to go in and remove any bone that is not solidified, meaning if there is any bone that is very soft, like what we call osteoid, which is like pre-bone or woven bone, you're going to remove that. You're going to get down to good base bone that you'll put the tent screws in and just build this back up. Secondly, do you remember when we use Oracell in the labs? You've used Oracell before, haven't you?
Yes.
Okay. I'm going to recommend an acellular dermis for some of the doctors who have never used Oracell. It is an acellular dermis, so it's basically an allograft skin. And what that does is that thickens up the tissue and makes the tissue a lot healthier. That will make it more aesthetic. It's a collagen membrane, so you can use that as your collagen membrane, Doc. So I would recommend using Oracell, do tent screws, and I would also, Doc, you've used osteofiber before? You used that in our
Yes.
labs? Okay,
Yes.
this would be a perfect case for osteofiber because what did you use to graft it the first time?
Mineral loss.
Mineros. Okay. if you don't mind changing Mineros, the problem with Mineros on a case like this is it's going to migrate all over the place. The osteofiber will maintain stability. It'll stay in that same place. It'll be a lot easier and a lot more predictable. Okay.
Right.
So I would have my recommendation, have a talk with the patient. If they want to go ahead and bone graft it, get back to Dr. Hussein or myself. We'll work it up for you where the tent screws need to go. And I can even walk you through the surgery before you do it. But definitely, you're going to need 4 tent screws, osteofiber, and a cellular dermis.
Now I'm going to have to reflect the flap pretty deep on the lingual to fill that large void on the lingual, correct?
Yeah, I'll tell you what, let's answer that question by looking at an X-ray. Let's look at an axial radiographic view, and I can show you
Right.
on a radiograph, yeah, how far the lingual has to be because, um, did you hear that, Dr. Hussein?
Yes, sir. I'm on it right now.
Okay.
It's just
Oh, okay.
yeah.
Oh, okay. So, Doc, with an axial view, we're going to be able to see where the nasopalatine is, how large the nasopalatine is, which will dictate how much of a flap there. So let's take a look here. Just 1 second. Keep going, keep going, keep going, keep going, keep going. Okay, right there, stop. Okay, stop right there. Okay, so let's blow that interior up so everyone can see it. And we'll enlarge it. And
Yeah.
okay, center that. And then if you, Dr. is saying, if you could just draw a little line for us, the curvature there, so we can
Dr.
see.
Dr. Resnick, I'm so sorry about this. My laptop is giving me a hard time. So just 1 second, sir. I'm going to share my screen from a different PC. So sorry about that,
Okay,
Doc.
okay. So let's talk about this, Doc. So the lingual, usually we don't have to reflect it that much, but on a case like this, I would probably reflect it enough that we can tuck the membrane in, and that would give us a security. Okay. The facial usually is the most significant part of this graph because you've lost so much of the buccal plate. When you lose it from buccal to lingual like that, the concavity is pretty significant, as you remember when he showed that to us on the 3D image. So if we look at it here, we'll be able to see it better on the axial view. So go ahead and, okay. And then we're just going to highlight that and enlarge it.
Here you go, sir.
Okay. Okay. Can you scroll back? Keep going back, 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 back. Okay. So Doc, see where the nasopalatine is?
Yes.
If we did not graft the buccal, you basically couldn't place an implant here. Draw us a line if you could on the curvature,
Here you
Dr.
go, sir.
Hussein. Okay, so that's the invagination I'm talking about. Now, show them the normal curvature of where it should be. Oh,
Right away. Let me change that color, Dr. Resnick.
okay.
And here we go, sir.
Okay, so that's where we're going to graft, Doc. Our
Okay.
graft is mainly going to be on the buccal, not on the lingual. However, we still have to use the lingual to tuck our membrane in so we don't get any micro movement on it. Okay,
Okay.
does that make sense?
Yeah, so I don't have to graft that lingual side of that ridge.
No, no, you don't. We don't want it on the lingual. We want it on the buccal because look at where the number 8 position is.
Right.
Okay. So we want number 9 to be in basically that same position on the other side.
Okay.
So the lingual plate will be insignificant on this. And just so you, as you remember from lecture, the lingual plate is very difficult to graft. And usually we don't have to unless there's trauma there. I don't think you'll have to do that. But what I'll do for you, Doc, is after we work this up, we'll draw the incision line for you, because you're going to have to really make this broad base so that you're able to close this tension free.
Right.
But we'll
Okay.
be able to do it papilla sparing incision, and then you're going to go 90 degrees to the mucogingival junction, and then you're going to flare out 45 degrees on each side, so you can really stretch that tissue. Okay.
Okay.
Okay. Nice case, Doc. And like
So,
I said, we'll help you with that. Did you have any other questions on that?
so do I just get in touch with Dr. Hussein, or what do
Yes.
I?
Yes. You'll have his email, because I believe you probably sent this to him. And he's real good. He'll get back to you and work
Okay.
this patient up. Okay.
All right.
And then they'll send it to me. Okay, Doc?
Thanks a lot.
Okay. Hey, thanks for sharing that. That's a good case.
Thanks. Bye-bye.
Okay. Okay, Dr. Hussein, we have 5 minutes. Can we do the last one?
Yes, sir. I've got the last
Who's our
one, and
doctor?
that's going to be Dr. Mandel. Unfortunately, the doctor is not able to make it in for today, but the reason why the doctor shared this case with us, Dr. Resnick, is that the doctor would like to add 2 implants at the sites of number 2 and 3, and he wanted your opinion about that patient. Keeping in mind, sir, that this patient is a smoker. The patient does smoke half a pack of cigarettes per day, no medications to be reported other than being smoker, 59 years old female patient, sir.
Okay. And I didn't have a chance to address the smoking on the last patient. Make sure you use that consent form that I have. It'll be on our website, on our modules. Make sure it's specific for smoking. That is definitely your get out of jail card for smokers, because as you know, we if the patient says they smoke a half a pack, it might be 2 packs or it might be a pack. So you never know. With that being said, let's do a 360 on this. We're looking at number 2 and 3.
Yes, sir. Right away. Here we go. Mm, Sure, I'm sorry about that, Doc. Here we go. Screens. Got it. Perfect. So can you see my full screen, Dr. Resnick?
Yes. Okay.
Perfect. So here we go. 2 and 3. Showing you right now
Okay.
the model.
So
So it's
if everyone can see right off the bat, see how much of the buccal plate has been lost there? You can see how it's invaginated there. So we have lost some of the buccal plate. So that should come out probably 2-3 more millimeters. With that being said, let's do a cross or a panoramic view. See what we have. And can we make the other view of that?
oh, here we go, sir.
Okay, perfect. And can I see the whole pan here, just so I can see what's okay.
Uh,
So right off the bat, Doc, everything. Okay. Oh, here we go. Good. Okay. So let's look at 2 and 3 position. Let's see a cross section.
right away, Dr. Resnick. I'm going to start from the distal aspect of tooth number 4, sir, and I'm going to scroll towards the distal portion, Doc.
Okay. So as you can see here, okay. Can we see superiorly to this? Or is it cut off? Okay.
No,
So
it's
we can
not,
see
sir.
the
Here
whole.
we go. We can
Okay.
see the whole thing.
Oh, let's show the ostium. So, okay, see the open ostium? Go back. So we need a lateral wall sinus graft. We always have to determine and make sure there's an open ostium. Dr. Hussein's going to show you the open ostium there, okay, which is nice and open. Let's go back to the panoramic view.
Right away, sir. Here we go,
So
Dr. Resnick.
with this case, we have less than 5 millimeters of bone. That means that we have to do a lateral wall sinus graft. Phase 1 of this case is going to be a lateral wall sinus graft. Phase 2 is going to be implants in the number 2 and the 3 position. Phase 3 is going to be the prosthetic rehabilitation. Because of the minimal host bone, there's probably 2 millimeters, possibly 3 at the most. What we're going to do is splint those that will distribute the forces a lot better and it'll be a lot stronger. So Dr. Sain, for Dr. Mandel, you can let him know. Phase 1, lateral wall sinus, the ostium's patent, which is perfect. This will be a ideal, easy lateral wall sinus case. There's no septum, it's completely clear. And there's a little bit of inflammation, as you can see in the sinus. So just blow that up so everyone can see that inflammation. Can you enlarge that right sinus so people can see it?
Here we go, sir.
Okay, so scroll. As you can see, there's a little bit of inflammation. That means that it's going to be really easy to reflect the membrane. You won't perf that. It'll be a lot easier. Other issues on this case to let him know, Dr. Sain, on the left side, move over.
Yes, sir.
Okay, they have a pseudocyst. That is a pseudocyst in the left sinus. It is benign. It is of no concern. I also, I think there is a pretty significant deviated septum here, which could be
You're
causing.
absolutely correct. Here we go, Dr. Resnik.
So,
Now I'm gonna.
so we can show
Here's
everyone the deviated. Oh, wow, is that deviated? Okay, show them that. Can you draw it for them?
here you
So
go,
there's
sir.
a significant deviated septum to the left. That means it's closing off the left ostium and the left osteomeatal complex, which is problematic. So that cyst on the right is a pseudocyst, not a big deal at all, benign, nothing to worry about. It probably has been there since the teeth were there. So this is a good case for 2 implants, nice lateral wall sinus, and I would recommend Dr. Hussein have Dr. Mandel make a surgical guide for the lateral wall. It'll be very easy and simple.
Yes,
Okay,
sir. I'll definitely
great.
pass the feedback. Thank you, Dr.
Great.
Resnik.
Well, hey, it's 8 o'clock. I never like to keep anyone late. Thank you for attending. If you have any recommendations, such as the question and answer with Dr. Robinette, or if you want a specific topic for me to talk about, we'll be back in 2 weeks. Every other Wednesday throughout the year, we'll be doing these Resnik Grand Rounds. Thank you, everyone. Have a good night. Take care.
Thank you, Dr. Resnik. Thank you, everyone. Bye-bye.